right, folks, we're going to go ahead and resume the second portion of our morning program. And our next speaker is Dr. Semhar Tewelde, who many of you know, most everybody here knows. Dr. Tewelde was actually our very first emergency cardiology fellow. She essentially created the program and created the pathway for all of the other fellows who have come through the program or currently are doing the program. And she currently serves as the Emergency Cardiology Fellowship Director. She finished the residency in 2012. The year after that, she did the fellowship. And since that time, she's been a member of our faculty. She has become a national as well as an international speaker. She's spoken at ACEP, Maryland ACEP, and also Mediterranean Conference in the past. She won AAEM's Young Educator Award in 2017, and she serves as director of Bedside Echo for several national courses. And she's going to be spending some time talking about a really challenging and controversial topic and provide hopefully some answers for all of us with this topic on atrial fibrillation in critical illness. So Semhar, thanks for joining us.
Thank you for having me. It is certainly a challenging topic. My only disclosure is 30 minutes is not enough time, even for someone that speaks as fast as I do. So buckle up, let's get started. Sick AF. What does that mean? I got a lot of text messages about my title. It is not inappropriate. What it means is amongst critical illness, there lies a spectrum. Some patients are sick and some patients are at extremis. And so that's different and we're going to treat them differently. We have all learned that in hemodynamic stability, specifically with tachydysrhythmias, you look for things like hypotension, ischemic chest pain, pulmonary edema. All these things warrant emergent cardioversion, right? That's what we've learned. However, we know that dichotomous teaching, meaning yes versus no, is far too simple, especially in medicine. When we think about circulatory failure in clinical practice, what do we know? It's complex, it has overlapping problems, and often they involve multiple things: the tank, the pump, the pipes, right? It's not as simple as one thing. And so how can we use a dichotomous answer to yes or no? Now let's think about heart rate, specifically how it affects cardiac output. It can have a mixed effect. In patients with mild tachycardia, the effect on stroke volume is negligible. So what does that mean? The heart rate predominates. And when the heart rate predominates, it slightly increases your cardiac output. How is this different from patients that have severe tachycardia? Severe tachycardia affects stroke volume quite a bit because it reduces your diastolic filling time. It results in a decrease in stroke volume, a decrease in cardiac output, and it results for up to 30% reduction in stroke volume. We have learned, again, things we've been taught, heart rate correction is foremost. However, we have also sworn our oath. First, do no harm. With that in mind, ask yourself a question. What is driving the instability? Then ask, is heart rate correction necessary? Okay, so reframe that. Primary AF, what does that mean? The tachydysrhythmia is triggering hemodynamic instability. Secondary AF, what does that mean? It is the result or consequence of an inciting trigger that is causing hemodynamic stability. We're going to go through some cases at the end to bring it all together for you guys. But with primary AF, what do patients look like? Typically, it's an abrupt onset. They look ill, although they may not be in extremis, and the heart rates are fast, usually greater than 150. Okay? This is rarely encountered. As Susy told us, syncope secondary to AF is very uncommon. So this is infrequent. What patient demographics have it? Accessory pathways, post-cardiac surgery, or new onset AF. Okay? Those are the people that you're gonna see this in. Again, very infrequently. So I just said these patients present with heart rates greater than 150. Now, another consideration for you. Can you have a patient with primary AF and hemodynamic instability with a heart rate of 110? What are your thoughts? As we know in medicine, there's always that special scenario. Certainly, in certain circumstances, patients specifically with maybe diastolic dysfunction, aortic stenosis, hypertrophic cardiomyopathy, have poor ventricular compliance. What does that mean? The filling time of the LV is shifted, to a later part of diastole. And what does that mean? That loss of your atrial kick, specifically with AF and dysynchrony, is going to cause hemodynamic instability, even at a heart rate of 110, let's say. So atrial kick is essential in these patients. Treatment. Now, what is the treatment? The question is, in primary AF, everyone is not unstable. They all look ill, but everyone is not in extremis, okay? So when you have a patient in extremis, that's the solely dependent treatment you have is electricity. That's the cornerstone. What is the success with electricity? Greater than 90%, so we like it, right? So again, have pads on and be ready because these patients can teeter that line. They are sick, but they may not be in extremis. Have the pads on. If they're unstable, cardioversion electrically is the way to go. And how can you improve your odds at success? 3 things. The first, go big or go home. They've shown in studies ramping your energy up is not superior. In fact, it can irritate the myocardium, so start at 200. Second, if your patient is alert and with you, do not cardiovert them without giving them a sedative. That's not nice. And in fact, they have endogenous catechols. When everyone runs in the room to a patient and says, your heart's gonna stop, what do you think the patient feels? Calm, tranquil? Probably not, okay? So give these patients some agents. I prefer fentanyl with etomidate or dexmedetomidine. Both of these are great. However, as we always do at the bedside with unstable patients, you should have a vasoactive. This is not the time to pull epi from your code card. What does it do to your tachycardia? Well, the beta receptors are agonized, right? So it's gonna go up. So this is the time to pull something like phenylephrine, okay? Placement, pad placement. There've been lots of studies going back and forth, AP versus AL. It seems like the most recent studies, EPIC trial specifically, looks at AL placement being slightly superior. So don't bother turning the patient, flipping them over. AL placement is fine. What can you do if a patient is intubated? For instance, you are gonna have thoracic impedance. Take them off the vent briefly while you're doing your cardioversion. Now let's talk about pharmacologic therapy. What are the success rates there? They're not that great, in fact. A good success rate with pharmacologics is anywhere from 50 to 80%. So we're comparing that again to 90% with electricity. So if you are using pharmacologics, understand that they are not as good as electricity. However, patients that are stable may not want to be cardioverted with electricity, especially if they've had to before, like those with accessory pathways. So there is a pathway to give drugs. So what are the best drugs? Let's talk about the 3 runners-up. Starting with class 1, again, Susy did mention this for us. Procainamide being the first agent, which is a recommendation amongst all the guidelines, AHA here in the US, Canadian guidelines, as well as European guidelines. So procainamide is a sodium channel blocker. It's a 1A. It moderately blocks the sodium channels. And in fact, it also affects the prolongation of the action potential by prolonging it and the effective refractory period, which is why we like it with accessory pathways, okay? So your non-nodal tissues, your non-conducting tissues, which is the most of the heart, most of the myocardium is non-nodal. We know the nodal tissues or the conducting tissues are the SA node, the AV node, the bundle, the branches, and the Purkinje fibers, right? So those are conduction or automaticity cells. Those are pacemakers and latent pacemakers, as opposed to the rest of the myocardium, all the other tissue. They can conduct, but they have a different type of conduction. So procainamide there is beneficial. Now, when they looked at studies comparing procainamide in AF to the next agent, which is a potassium-sparing, potassium blocker, ibutylide, the studies are mixed. It seems like many studies have shown that ibutylide is slightly superior to procainamide. Procainamide does have a little bit of negative inotropy and hypotension in several studies. These studies are heterogeneous. These studies are looking at different patient populations, and so it is very difficult to give a straight answer, which is why this is a tough topic. I will say that there's some benefits and negative aspects of both drugs. Procainamide, the biggest one again, negative inotropy, some hypotension. Ibutylide, QT prolongation and the possibility of torsades. If given with magnesium, that is much lower. The efficacy seems, again, that ibutylide will win out over procainamide slightly. Again, these success rates are anywhere from 60 to 80%. How long do these 2 agents take to work? The studies show about 60 to 90 minutes. So if you have a patient, again, who's teetering, but not completely unstable, so doesn't need cardioversion electrically, you can utilize these agents because they work fast. You may imagine the next drug I'm going to talk about is amiodarone, the one drug to rule them all. That being said, amiodarone works very slowly, okay? Hours, in fact. So amiodarone is actually not a drug I'm going to pull for primary AF. We'll talk about it with secondary AF, but if I have a patient that I want to get out of AF quickly, within the next hour or so, and I'm not going to use electricity because I don't need it right now, they're not diaphoretic and circling the tank, I'm going to pull one of these agents. Now, there is a new kid on the block. Her name is Verna. She comes to us from Canada and from the UK. Unfortunately, here in the US, we don't have Verna. Verna is a pure potassium channel blocker, similar to Ibutylide. However, it has an affinity for the atrial myocytes, and so Verna works in 15 minutes. So if I had her, I'd be using her here. Unfortunately, fortunately, there are studies comparing her to Ibutylide, and it shows that she is superior. So if you have it, I think I would prefer to pull this agent. And finally, class 5, and I should say that in 2018, the Vaughan Williams classification scheme has changed. So class 5 is no longer the agent we're going to discuss, but I'm going to use the old scheme in case you guys are wondering. So magnesium, love it. It helps with rate control. It helps with rhythm control. How does it do it? I have no idea. It is a cofactor on your sodium-potassium ATPase pump. And we'll talk about digoxin and how that works on that pump. So magnesium works as a cofactor on that pump, and it also works with your sodium-calcium interchanger. What does it do at the end of the day? It's known to increase the effects or magnify the effects of multiple antiarrhythmics, again, used with Ibutylide. They've done studies looking at magnesium alone against other antiarrhythmics, such as amiodarone, showing that magnesium is just as efficacious. So when I have a sick AF patient, it doesn't matter the etiology, primary or secondary, they're always getting magnesium. These patients should be bolused 4 grams over an hour. So we're talking about Torsades bolusing. And yes, I know we have patients here, especially in Baltimore, with renal dysfunction. Honestly, if they're that sick, I'm giving it to them anyway, and then I will follow their MAG levels. And don't forget, we can check for side effects, right? We all did MAG checks on OB, so look for the side effects, right? And certainly giving it over the hour is going to reduce the side effect of hypotension. Secondary AF. How does this present? Very frequently, unlike primary AF. These patients typically present in various fashions because any patient can get it, as we'll talk about shortly. So the patient presentation is based on each inciting factor. For example, a patient that is a nursing home patient that has a GI bleed of insidious onset is going to present a lot differently than the patient with acute hemiplegia from a stroke. Both of them can have AF as a secondary mechanism. And we'll go through some cases shortly again. When we talk about why do people get secondary AF, anyone can get it. And as you see here, over time, there are some things that are non-modifiable. The older you get, the more likely you are prone to get AF. That being said, there are modifiable things, hypertension, obesity, smoking. And then there are triggers. So we know that AF often originates somewhere in the pulmonary vein. So if you have pulmonary issues, in COVID, we saw it a lot. With pneumonic infections and sepsis, you'll see it more often. So there are substrates that then can lead to people getting it. All of these things combined increase your threshold, and then there's some event, whether that is, again, the stroke, the GI bleed, many inciting triggers that we'll shortly talk about. That is what happens, and then you get AF. It does predispose you to having AF in the future. Not that everyone will develop AF in the future, if that makes sense. Plenty of people had AF during an acute COVID period, and then they looked at them thus far over the last 1 to 2 to 3 years, now that we're post out of COVID phase, and not everyone has gone into AF. Obviously, we have many more years to go. Some technical difficulty. All right, let's start with inciting triggers. Can you fix this? Thank you. Treatment for secondary AF. Treatment for secondary AF is based on the patient presentation again, and that trigger or those different triggers are vast. The key to them is first identifying. Thank you. The trigger is first identifying the most important thing you can do is identify the trigger and treat it. So I'm gonna utilize the tank, the pump, and the pipes to go through some common things. This tank is your O2 tank. We frequently see patients with hypercapnic or hypoxic respiratory failure. How are we gonna address them? The same way that we always address them. COPD, asthma, heart failure, pneumonia. You're gonna give them CPAP, BiPAP, high flow nasal cannula. You have a large PE, you're gonna give them TNK. Let's talk about the pump. Cardiac ischemia, mitral regurgitation, or acute aortic stenosis. Those people are gonna require a cath, or those people are gonna require mechanical support, whether that's surgery or mechanical circulatory device in the setting of shock. The pipes, well, leaky pipes, we're very good at that. Antibiotics, we throw it in the water. Don't forget to think about an acute GI bleed. Maybe they need blood. Thyroid storm, they might need thyroxine or steroids. So we're gonna treat each patient based on their clinical context. AF is compensatory. What does that mean? There's a stressor, and AF is how you compensate. It doesn't mean that the tachydysrhythmia is causing you any hemodynamic instability. You're gonna ask me, what heart rate do you look for? I have no idea. I have no idea. That being said, what I wouldn't utilize is the race trial. The race trial says lenient heart rate control to the 1 teens is okay. Those are not critically ill patients. Those are stable patients, and they ambulate, and they said, okay, you don't have to be as strict. What we do know is some people need stricter heart rate rules if they're sick, maybe 1 teens, 120s, like if you've had cardiac resynchronization therapy, you have mitral stenosis, you have angina, those people, you don't want their heart rates riding too high. Now, other people, let's just say you're a healthy 50 or 60-year-old, you can be 140s and 150s with your sepsis. It's okay. Once I treat that sepsis is when you'll improve. What is the most important thing I can do for these patients? Most important thing I can do for these patients are dealing with your other sympathetic issues. Thank you. Sorry. Okay. All right, maybe my fingers don't work. I have a magic finger. It works on electricity. All right. So, assess for other sympathetic causes. And what do I mean by that? Pain, anxiety, I'm having a little bit right now. So give them some fentanyl, give them some Ativan, withdrawal, again, Ativan, agitation, dexmedetomidine. These are all things that can be secondary going on. Maybe they have sepsis, maybe they have a fracture, whatever the etiology is, ensure that you are taking care of it. I think it means I need to stand behind this. All right. The heart is finicky. And what can you do to optimize, as is the remote, you're right. So since the heart is finicky, what can we do to optimize the success of treating your secondary AF? There's two things. Optimize your volume status, and then optimize your cardiac milieu. So what can you do? A couple of things. A thorough exam, a bedside echo, and get some labs. And how is this going to help you? The heart does not like to be stretched over or under. So if a person is volume up, diurese them. If they are dry, you need to give them volume. And how are you going to tell? There's a couple of ways. The most important thing is to look at the IVC, to look for apical B lines, and to look at your function. All of those things are going to help you. So if you have a flat IVC, you have good respiratory variation, and you don't have apical B lines, even if a person has heart failure, consider giving them a small fluid bolus, 250 cc's, small fluid bolus. Consider if they have sepsis and they are acidotic, they may need bicarb as their source of fluids, okay? So bicarb-infused fluids as opposed to maybe giving them plasma light, which is what we usually reach for. Of course, hypo-K, hypomag, again, with the heart being so finicky, make sure you replete your electrolytes in addition to addressing acidosis, diuresis versus volume. Those are the important things. And when you give vasoactives, not beta agonists. So I know we love norepinephrine. It is probably the one drug that does rule them all. It is probably the agent we pull the most when things are undifferentiated. Just understand you're going to have beta activity. So if you can, this is the time to think about vasopressin in your septic patient or phenylephrine in pure primary AF. Now, what is NOF? new onset atrial fibrillation. This is associated with critical illness. This is seen about 10 to 20% of patients with critical illness. It means you're probably going to be really sick and it's going to be hard to treat you. Here, your AF is not only compensatory, but it can be contributory and it can lead to a vicious cycle. So what are the things that we're going to look for with NOF, or how do we know a person has NOF with long boarding times? There are a couple things. I've treated your inciting trigger. So I've given you 15 or 30 cc's per kg based on you have renal function or heart failure. I've given you antibiotics. I've waited 3 to 4 hours. I've repeated your lactate. It's not trending down. Your heart rate is not appropriately responding. I've made sure I'm not giving you any beta agonists. I'm treating your pain or your agitation or your sedation, and yet the markers are not changing. Nothing has budged. That means I may need to address their AF, okay? What is the prototypical situation this happens in? AFib with heart failure. I get a lot of questions about this with my residents all the time. This is not easy. However, think back to the beginning of this talk. Primary AF, how do they present? Abruptly looking ill. This happens in heart failure patients actually prior to the development of heart failure. So what do I mean? A person has early classification, hypertension, hyperlipidemia, does not have a diagnosis of heart failure, has AFib. AFib has caused a tachycardia-induced cardiomyopathy, and now this is new onset heart failure. So those people look pretty sick. As opposed, again, very infrequent, just like we talked about with the other etiologies of accessory pathway, new onset AFib, post-cardiac surgery. That is different than the far majority of patients you're gonna see with chronic decompensated heart failure. What happens? Those people slide down the New York Heart Classification. Class 2, Class 3, Class 4, shock. Maybe they go on to a VAD or a transplant. Those patients frequently have AF. AF increases your probability of having heart failure 5-fold compared to the general population. So in 50% of cases, people are gonna have AF and heart failure at the same time, okay? So when you have a patient with heart failure or AF, you're gonna go back to the basics. We're gonna talk about the tank, the pump, and the pipes. You're gonna treat them. Pulmonary congestion, systemic congestion, tissue perfusion, okay? We do this every day. We're great at this. This is our bread and butter. Pulmonary congestion, what are you gonna do? Put them on BiPAP or CPAP, whatever you have. For oxygenation, it's gonna help you with vasodilation, right? Your pulmonary vascular beds are gonna be vasodilated when you decrease that preload. These are the patients that are sick, so not the hypertensive patients you see. So you can't start nitro on these patients because their pressure is 100, so start with just your non-invasive ventilation. Next, systemic congestion. Although generally we talk about patients with heart failure being potentially up to 50% not volume up, look for systemic congestion, because if it's there, you need to diurese them. So again, the pump needs help, so diurese it when necessary. Tissue perfusion, what are the markers? Urine output, cap refill, lactate, LFTs, renal function. You're gonna look at all those things and you're gonna say, does this person need an inotrope, right? Or do they need a support device? Tank, pump, pipes. We do this every day. Now, so the primary trigger was your heart failure. Your secondary AF, your secondary AF is how you're gonna treat it. After you've treated the primary trigger, if that doesn't work, now we need to go on to address AF that is contributory, causing this vicious cycle. The slide I showed you 2 prior to this had a lot of words on it. What does it mean? It means that heart failure and AF are interrelated complex things, and they cause a vicious cycle. And so there's no way that these patients are probably gonna get out of AF, which is very common. So if you try to cardiovert them, it's probably not gonna work. What are you gonna do to augment or optimize your chance at success? You're gonna give them an agent first. We're gonna go through some agents that are great. So pharmacologic therapy plus magnesium always, and then attempt to cardiovert if necessary. Sometimes just giving mag and the pharmacological agent is gonna bring your heart rate down enough so they don't need cardioversion. When all else fails, call the cardiologist. Patients go for ablation. I had this happen last week. Questions so far? I'm doing okay on time. Pharmacologic agents, again here, pharmacologic success, anywhere from 50 to 80%, so it's not great. But what are the agents I'm gonna use here? 3 runners up again. Verna is not included here, although she can be, but I'm gonna talk about 3 other agents. The first of which is a class 5 agent, sodium Potassium ATPase agent, digoxin, we talk about it a lot in heart failure patients. Why is it great? It helps with slowing down the heart rate and also increasing your inotropy. So it's great in heart failure patients. What are the downsides? It's not going to work fast. You're going to give it, and maybe 4 to 6 hours later, you're going to see the effect. I don't know about you guys, but we have a lot of boarding in RED, so I've given digoxin certainly. That being said, understand that it is not going to potently reduce your heart rate. So I like it when the heart rate is up 10 to 15, maybe 20. If I have a heart rate that's, let's say the patient is 80 years old, and I consider them, again, secondary AF for me is like a sinus tach equivalent. 220 minus age is what I look at, and that's kind of my rough my rough gauge of heart rate that I'm looking at and how can I fix it. If I need to fix it more than 20 to 25, DIG might not be the agent I pull for. Second agent, again, potassium blockade. We talked about this with Ibutylide. We talked about this with Verna. This is a bit different because we know amnio is a bit of a dirty drug. It works on class 1, it works on class 2, it works on class 4. Why might that be good? Because actually in patients with secondary AF, their sympathetic surge is up, and I want to block the sympathetic surge without dropping the pressure too much. So amnio is good in this way because it gives you a little bit of beta blockade, which is why also class 2 agents, which you typically hear, do not use beta blockers in heart failure. Yes, in the acute phase, if I think I need to intubate you or if I'm diuresing you, but that doesn't mean hours down the line, they might not need a little bit of beta blockade. So hopefully that makes sense. Amnio here again, it works slowly. If I have a primary AF patient and I want to get them out of it, I'm not going to pull amnio because it's going to take hours to work. Amnio does cause hypotension, although you'll technically, people will say it's more hemodynamically stable. It is compared to some agents. I'm not going to pull diltiazem in a patient with sick AF that's hypotensive. Amnio would be an agent that is not going to drop your pressure or be as negative an inotrope as something like DILT, which certainly is a calcium channel blocker, right? So amiodarone, although it is dirty, I do like some of the properties, and I will say it is a class 1 recommendation across all the guidelines in critical illness. That being said, is there anything else that may be as beneficial? Well, the first thing I think of in a class 2 agent, we talk about esmolol, right? Easily titratable, so fast acting, easily off. It does have negative inotropic effects, and it also does cause hypotension. However, there is a new school agent also available in the UK and in Canada that is either 10 or 100 times more potent than esmolol, does not cause as much hypotension or negative inotropy. In fact, has also been studied in heart failure patients specifically. So if I had one agent in this group that I probably would pull, it would be Landiolol. That being said, I think amnio and esmolol are great for more robust heart rate control in secondary AF, and if I'm boarding a patient for 6 to 8 hours, and I've already addressed all the inciting triggers and nothing is working. We talked about a lot of agents. Sick AF is very hard. You have an armamentarium that does not include calcium channel blockers, if you notice. They are great in routine AF patients. I would not pull them in sick AF patients. Don't forget to separate people from primary and secondary etiologies. Secondary must have treatment of the inciting trigger. When you do it, often you don't have to pull these other agents, but don't forget we have a spectrum of NOF, and those patients, AF is going to be contributory as well as compensatory, and they are going to need extra help. Often this doesn't happen in the ICU. Nowadays we're boarding for much longer periods of time, so I want you to think about all the different drugs you have at your disposal. I'd like to bring it all together with a case I had a couple weeks ago. This patient is 84-year-old female. I'm going to call her Miss AF. She came in after a week of URI symptoms, cough, congestion, worsening dyspnea. She has a known history of heart failure. She's had CRT, cardiac resynchronization therapy. These are her vitals. A little bit alarming, so I go get up to see her quite quickly. I think actually the resident came to get me. So this is her echo, and as you can see, her function is not great. That being said, she did not have apical B lines, and her IVC was relatively variable. Not 50%, but it was not bad. Her ECG, nonetheless, I didn't show it here, but it's no surprise she had AF. This is her x-ray. Certainly looks volume up, of course, as the radiologist would say. I don't think we need a radiologist for this, but she had a week of symptoms, cough, congestion, rhinorrhea, Is there underlying pneumonia? I'm not sure. She had a low-grade temp. So she got treated for pulmonary flora, which I think at her age is completely acceptable. But don't forget, with shock, especially cardiogenic shock, not saying she had it, she wasn't cool, she was warm to the touch, but when you're thinking about cardiogenic shock, 50% of patients have a mixed shock. So they're gonna have an inflammatory cascade septic component. And so we thought about this appropriately so. So she got treated with a small amount of fluid, given her echo, 250 cc's, and then she got all the drugs, of course, for pulmonary flora, and then she was still hypotensive, so we gave her vasopressin, arginine vasopressin, as opposed to norepinephrine, because her heart rate was up. A couple hours later, these are her vitals. Not good. We discussed cardioversion with her. She was amenable. We attempted. She still was an RED for a long period of time. So this is her heart rate, and this is her next heart rate. Round 2. This was about an hour after that. We gave her all the things that we would give a person with secondary AF and heart failure. She got MAG, she got amnio, she even got a second attempt. It didn't work. She stayed on amnio for a while. By the time she went upstairs, it did. Her heart rate was down, which is good. That being said, her tissue perfusion markers did not improve, which meant her blood pressure stayed in the 80s to 90s. Her lactate would not clear. She was started on milrinone. Guess what? It worked. All the stuff got better. Unfortunately, she could not be weaned from milrinone, so she went home on a milrinone infusion. Okay? And this is often what happens when decompensated heart failure gets bad again, and you slide down your New York classification. You can't reverse the heart failure, and sometimes people are going to go home on infusions. Sometimes they would get VADs. Potentially, she's an 84-year-old lady, so that was not discussed with her. And I do think they actually discussed possible ablation with her because of her CRT. Patients with CRT, cardiac resynchronization therapy, do get AF, and ablation can work in a subsegment of those. So what did we discuss today? A pretty tough topic. I want you to remember, think about primary versus secondary AF. What is the trigger with secondary AF? Everyone has compensatory AF in the secondary class. Primary AF is different, right? That's the cause. But with secondary, you can have a compensatory AF, but it can also be contributory. So when it is contributory, you may have to treat it. Optimize your success by checking volume status and ensuring a good cardiac milieu. Think about the optimal pharmacological agents. They are different based on every patient and their clinical scenario. So every patient is different. So treat them as such. And then cardioversion only when necessary, which is not actually frequent. I have a slide for you to review at your leisure for everyone that has the notes section. It was wonderful talking to you guys, and I'll take questions.
Thanks, Semhar. Maybe time for one question, Dr. Miller?
The talk was so excellent that all your questions got answered while you continued to give it, so I'm not sure if there's any audience questions.
There's no question about why the clicker's not working?
Let me, let's see. I got a couple questions. Let's see. Somebody said that this physician has been out in practice for a number of years and remembers when ibutylide first was introduced, and one of the drawbacks to using ibutylide was the risk of torsade. Is that similar for the vernaculant?
Yeah. Actually, no, because Verna specifically attracts or has an affinity for the atrial myocytes, the possibility of or the likelihood of proarrhythmia is a lot worse. It does still prolong your QT. That being said, thus far, the studies show that it is much less likely to cause torsades. And don't forget, procainamide, which we also discussed, is very proarrhythmic. When you consider class 1, it has A, B, and C. And the A class, where procainamide is, moderate sodium channel blockade, is the most proarrhythmic of all three subtypes of class 1.
Any idea when vernaculant would be available?
I think they are in the process of trying to get FDA approval now.
US.
Yep.
All right,
15 minutes.
It's available in
Canada and across Europe, correct.
All right, interesting. All right. Okay, all right, thank you so much,
You're
Dr.
welcome.
Tewelde.